Okay, good to go. Hello, I'm Dr. Anglin with Comprehensive Orthopedics and Sports Medicine. Sorry, we're just ran into a few technical difficulties, so now we're set up and going. So I appreciate everyone dropping on this morning on a beautiful Friday morning. So we'll get started. So I just wanted to kind of briefly mention my team. So it's myself, and I have two amazing assistants, an athletic trainer and a medical assistant. So Skylar and Rachel, who really keep things going for me, make sure I'm going to the right rooms, and also help a lot with patient education and helping facilitate your care. So I appreciate them. And then globally, the whole comprehensive orthopedics team, which are my partners. So my orthopedic surgeons that I work with, which they're amazing and can pretty much do anything in terms of orthopedics or musculoskeletal, whether it be disc replacement in your neck, ACL reconstruction, joint replacement, EMGs, everything across the board. So the great thing about comprehensive orthopedics and sports medicine is we are all partners, and I feel comfortable sending any of my patients to any of my partners because I know they're good people and they'll take great care of my patients. A little bit about kind of how I got into not just sports medicine, but orthobiologics. So I finished my fellowship, my sports medicine fellowship in 2016, and really, for the first 5 years of my practice, operated under kind of the standard non-operative sports medicine practice, which is prescribe anti-inflammatories, PT, steroid injections, and then surgical referral. And I got tired of doing this very basic approach because I would offer patients the same treatment options that oftentimes didn't work. And there was no growth in that. So my patients deserve more than just the standard options. And we want to treat the whole person, not just the pain. So the discussion today is about our approach, or my approach, to knee osteoarthritis. So how can we relieve pain, avoid surgery, and get you back to the things that you enjoy without the traditional approach of just steroid injections, PT, and then you need a joint replacement. So a few myths that we want to kind of bust today. In terms of your knee pain or knee osteoarthritis is that your only option is surgery or steroid injections. Where the truth is, orthobiologics like PRP, that's one example of it, can reduce your pain and delay or prevent surgery. The myth that you need to just stop moving, sit on the couch and rest. Truth, I tell my patients this every day, that motion is lotion, motion is medicine. We got to keep you moving. And I see patients in their 80s, sometimes 90s. These are sometimes some of my most active patients, really confirming that you got to keep moving, you got to keep doing stuff. Number 3, it's just wear and tear, nothing can help. Truth, knee pain is complex, and we'll talk about this. We're going to talk about how we treat the knee as an organ. So it's not just cartilage loss. And number 4, total knee replacement always works. Truth is, about 1 in 5 patients are still having some pain or still unhappy after a knee replacement. And this is kind of unique to knee replacement, that there can be more difficulty getting that range of motion back in a knee after a knee replacement in comparison to hip replacements, which typically respond pretty well to a replacement. So talking a little bit about how many people this affects. So the epidemiology of osteoarthritis. I don't want to bore you guys too much with numbers, but this affects a lot of people. About 500 million people worldwide are affected by osteoarthritis. 32 million adults in the US have osteoarthritis, and knee osteoarthritis is kind of the most prevalent. Women are at slightly higher risk than men, especially after the age of 50. So I get asked a lot about risk factors. Why do I have arthritis? Is it just because my mom or dad had arthritis? And I would say it's multifactorial. So probably the number one risk factor is age, after the age of 50. Doesn't mean you can't see it before the age of 50. Obesity. So excess weight increases joint stress. So for every pound over your ideal body weight, that's 4 additional pounds of pressure across the joint. Joint injury and overuse, especially in Utah with skiing and other mountain activities, we see a lot of ACL tears. And those, unfortunately, increase your risk of osteoarthritis. Genetics does play a role. We just don't know how much it plays a role. And then if you have some misalignment in your knee, what we call like a valgus deformity or a varus deformity, or just poor biomechanics, or your quad is really weak, or you've had an injury and your quad is really weak, that can increase your risk of osteoarthritis as well. So orthobiologic treatments, basically orthobiologics is kind of a fancy name for we're using your cells or your tissue to try to stimulate healing in a joint or a tissue. And so there's different types: platelet rich plasma, bone marrow aspirate, microfragmented adipose tissue. There are other types that are not FDA approved that we're not using in our clinic. So a lot of people talk about amniotic derived products or Wharton's jelly or cultured stem cells. None of this can be used in the US right now. So we're staying within FDA guidelines, and everything we use is taken from you and injected back into the injured area. So different things that we can use orthobiologics for. So 2 pictures here on the left, that's me holding microfragmented adipose tissue. So we pulled some adipose tissue from a patient, we spun it down, fragmented it, washed it, and injected it into their joint. On the right is PRP, sort of a punch-colored solution. So we can use this for lots of different things, not just osteoarthritis. So I use this a lot for osteoarthritis, but also tendon or ligament issues, platelet poor plasma for muscle injuries. They did a study at the University of Iowa on that, on hamstring injuries. Found that platelet poor plasma actually worked better than platelet rich plasma. Spine conditions, so when we're treating the spine, we're trying to treat the whole functional spine unit. So traditional pain medicine, we talk about finding the one pain generator. Oh, it's your facet, or it's your muscle, or it's your disc, or it's your nerve. When it comes to regenerative treatments in the spine, we're trying to treat the whole functional spine unit. So the facet, the ligaments, the muscle. So we're trying to be more comprehensive in our approach. And then post-surgical healing as well. So really trying to speed up the recovery process. Why do we need orthobiologics? There's a huge treatment gap in orthopedics, especially when it comes to osteoarthritis. We're seeing patients with knee osteoarthritis at younger ages. So we could see, a 40-year-old with knee osteoarthritis. Well, we know that knee replacements last anywhere from 15 to 25 years. Well, that 40-year-old's going to, likely live longer than 15 to 25 years. And so they may need a revision at some point. So we're trying to bridge this gap. Doesn't mean that they may not get a knee replacement in the future, but we're trying to improve their function, reduce their pain in that time period. If we just do repeated steroid injections, it's really going to just push them into that knee replacement more quickly. So, kind of going through some of these studies are indicating that, repeated corticosteroid injections can be chondrotoxic, meaning they're not good for the cartilage in your knee. They're definitely not good for a tendon. I would never inject a steroid into a tendon because it's just going to increase the risk of rupture. Anti-inflammatory, so NSAIDs, so like ibuprofen, diclofenac, Aleve, naproxen. Yeah, you can take these for a short period of time, and they work great, but you don't want to use that for a longer period of time. It's going to lead to GI issues and kidney issues. And we think that maybe NSAIDs disrupt the natural inflammatory process that's going on in a joint or tendon that may actually be helping to heal it. So they can relieve pain, but they may slow down that repair process because we need inflammation to a certain degree for repair. Patients who can't have surgery, they have a terrible looking knee, but they have other medical comorbidities that they can't have surgery. Or, in some cases, surgeons will not do a knee replacement if your body mass index is over a certain level. Like we stated before, if you're too young for a joint replacement. And then just really, let's offer all the options. So patients are becoming more and more aware of orthobiologics or stem cells. And so we want to educate you on the options. And patients are coming in educated. They're asking, wow, what PRP machine are you using? How many platelets are you injecting? So that's great. So the knee as an organ. So, most people that come in, they're like, oh, is my cartilage gone? And that's not the only factor with knee pain. Yes, degeneration of the knee involves loss of cartilage. So the cartilage is that spongy covering to the bone that helps the bones glide past each other. That is one component, and oftentimes isn't really the pain generator in your knee. More often, there's two other things that really drive pain. One is the subchondral bone, and that is the bone underneath the cartilage. So sometimes we'll do an MRI on patients with knee arthritis, and yes, we see some of that cartilage worn away, but underneath, we see bony edema, or sort of like a bone bruise, and that can really drive pain. And really cause more pain than the cartilage loss. The synovium, which is the lining of the joint, that's what secretes synovial fluid that helps lubricate the joint. And when that synovium gets irritated, or what we call synovitis, that can be a big issue with pain as well. If you have a ligament or meniscus issue, that's going to change the mechanical stability of your knee, and it's going to load different areas of the joint. So if we don't pay attention to that, it doesn't matter what we inject in the knee if there's a biomechanical deformity, or if the knee isn't aligned appropriately, or we're not tightening some of those ligaments. So sometimes we'll inject PRP into the MCL to kind of stabilize when somebody has a valgus deformity. That can be additionally helpful. So we're trying to treat the whole knee. If you have a weak quad, you're going to load that knee more. So again, doesn't matter what we inject in the knee. If you have a super weak quad and it's not offloading the knee, then you're still going to have symptoms. Nervous system. When you have pain in an area for a prolonged period of time, it starts what's called central sensitization. So your brain starts getting more pain signals, and it sets up a bigger antenna for those pain signals, and that can really drive pain. And then if you have any impaired circulation, our body needs to clear out some of those inflammatory substances in the knee. So if you don't have good vascular or lymphatic system or impaired circulation, that can affect it as well. So kind of like I was stating, why treating the knee as an organ matters. All these different anatomic elements are connected. So damage to one area can affect the other area. The mechanics, it's both a mechanical structure and a biological system. If we only addressed one part, we may not get you pain relief. And, a little example of this, before we talk, when I have a patient come in, before we even begin talking about what I can do in terms of injecting something, we talk about what the patient can do. So there's a lot of things you can do before you even walk in my door. And, looking at kind of ideal body weight. We want everyone to be sort of at their ideal body weight. And my best example of that is, what were you when you graduated from high school? What weight were you? And so if we can get as close to our ideal body weight as possible, we're going to offload the knee. So for every 1 pound of weight lost results in 4-pound reduction in knee joint load. And this was a study that they did on it. 10% weight loss resulted in improved pain, function, and quality of life. And then quadricep strengthening, just very basic. You don't even necessarily have to go to a gym or see a physical therapist, but 3 sets of 15 reps of just knee extension aimed at the quad can improve your pain and quality of life. And these are things we will help you with. So if you come to the clinic, you just don't even know where to start, we can find ways for you to get stronger, and we can help you design a rehab plan. We can help you with weight loss. There's lots of resources out there now. So this is a big thing is, a lot of people walk in my clinic and they feel like they've kind of been dismissed. And on average, patients come in having seen, up to 3 other providers. And they basically said, hey, I had x-rays, they threw my x-rays up, or they showed them to me quick, and they said, you got bone-on-bone knee arthritis, you need a knee replacement, or you need a steroid injection. And they weren't provided with any education beyond that. And that's, to me, isn't necessarily always the people that they're seeing. It's it's a system issue. It's the way we're set up now is to see more patients in a shorter amount of time. And what's lost on that is a lot of the patient education that goes on. People just want to understand what their options are, and they don't want to be treated like a number. They want to be educated. Okay, what can we walk through all the options, the pros and cons of each one? And so I feel it's necessary when people come into my clinic, like, I want to educate you on all the options. If you need a knee replacement, then you need a knee replacement. I'm going to get you to the best surgeon who does knee replacements. But we're going to talk through all the options. So we don't want you to feel trapped and feel like you got to search the internet to find the answer. You are more than your x-ray. So, here's an x-ray showing severe medial compartment osteoarthritis. And I could have 2 different patients walk through the door, and one could have severe debilitating pain, and one could be running marathons and they have these knees. So do both of those types of patients need a knee replacement or an injection or anything? Even if you have these x-rays and if you're feeling great, then maybe we're just going to focus on, okay, how can we keep your quad strong? How can we prevent progression of this? We're not going to say, oh, your x-rays look like this, therefore you need a knee replacement. So a small example, and I have lots of examples, case examples of patients who have been successful with non-operative treatment options, biologic treatment options. So Sarah, which is not the actual patient's name, but this is a real patient, 60-year-old Pilates instructor. She came in to me and she had seen a couple other surgeons, and she had a MRI which showed a meniscus root tear, which is a pretty big deal because the meniscus provides a lot of stability for the knee, and when that root tears, it normally leads to osteoarthritis. And she was stuck in this in between where, if she was 40 years old and she had a meniscus root tear, they would repair that meniscus root tear to prevent the progression of osteoarthritis. But no surgeons wanted to do that just because she already had a little bit of osteoarthritis. And she is super active. She's a Pilates instructor, big time cyclist, and she had a steroid injection, but she knew of the risks associated with steroids and didn't want repeated steroid injections. She had viscosupplementation, which helped to a certain degree, but she wanted to try other options. And basically I said, hey, we can try PRP. I can't guarantee it'll work, but it's not going to hurt your knee. And it has the potential for healing. And we did a couple of rounds of PRP. She went on a 10-day cycling trip throughout Italy, and now is back to instructing Pilates. And honestly, she's one of my biggest referral sources because she saw the powerful effects of what can happen with something other than the standard. So why PRP and orthobiologics work? So this isn't just my opinion. This is something that is studied. And there's probably 5 new articles a day that come out about this. And this has evolved over many years. And our studies have gotten better and our PRP has gotten better. But just a small sample, and we'll just go through a few studies. But PRP has been compared to hyaluronic acid injections, so gel injections, Synvisc, Uflexo, Orthovisc. And those types of injections I use very frequently in my clinic, and those are great options. And it is something that we use for osteoarthritis. But they did compare PRP to it, and PRP was found to outperform hyaluronic acid injections. And really, the way it outperforms it is it works for a longer period of time. So, maybe you get 4 to 6 months out of hyaluronic acid injections, and you get a year to a year and a half out of PRP injections. Next one is subchondral BMAC. So Philippe Hernigou, who's this French orthopedic surgeon, I think he's in his 80s now, has done amazing studies on bone marrow aspirate. And instead of just injecting it into the joint, he is actually injecting it into that subchondral bone. So that bone that we talked about that sometimes causes more pain for patients, he did a study, and we'll talk about it in a little bit, but basically injected bone marrow aspirate into the femoral condyle, into the tibia, into the joint, and had some amazing results. Next, this Atlanta study, 60 to 75% of patients delayed or avoided knee replacement for 2 to 5 years. So maybe you're just not quite ready yet. This could be something that could prolong the health of your knee currently. And again, back to this Hernigou, up to 80% of patients avoided knee replacement at 15 years when BMAC was injected in the subchondral bone. And we'll kind of go into that study a little bit more in a bit. So single injection for PRP. So I get asked a lot, do we do 1 injection? Do we do 3 injections? And really it's the dose that matters. Some of the early studies on PRP for any condition, but knee arthritis in general, is that the initial study showed that PRP didn't work very well. They compared PRP to normal saline, and they said, oh, normal saline and PRP work about the same. But when you dig into the methods, there you look at the PRP concentrate. So what was the platelet count? And in these early studies, the platelet count was low. They were only drawing like 15 milliliters of blood. They were barely getting 2 times the baseline level of your serum platelets, and so it wasn't working. And as biologics has evolved, we're finding that the higher concentrate of platelet count, the better patients are doing. So in this one, they had a platelet count greater than 10 billion. So that half the patients got PRP, half of them received hyaluronic acid, and the PRP outperformed in, these are all functional measures. So WOMAC, and then the visual analog scale, so your pain scale, and then walking distance. They didn't necessarily show that it increased the cartilage thickness. And this is something that is touted. You'll hear this on commercials. Oh, we'll regrow your cartilage, this, that, and the other. But we can't necessarily say it regrows cartilage. But we do think it's chondroprotective. So you see that maybe it didn't increase the cartilage thickness, but the PRP patients lost less cartilage in comparison to the HA patients. So the 3 injections. So you'll see, the PRP dose was a little bit lower, so 4.2 billion platelets, but they did it in a series of 3 injections. And these patients did well, even up to 60 months follow-up. The other thing that is interesting in this study is that they looked at cytokines, so TNF alpha and IL-1 beta, which basically are kind of catabolic cytokines, so they cause a lot of breakdown in the knee. And these were lower in the PRP group in comparison to the sham or control group. And they had 50% less cartilage loss in the PRP group at 60 months. So that's huge. Bone marrow concentrate. So this is where we pull bone marrow from your pelvis. It sounds really scary. All the patients that I've done it on have tolerated it spectacularly. I even had a few patients, we're finished pulling the bone marrow and they're like, when are we gonna start? So we do a great job of numbing you up and making sure that this is as comfortable as possible. This is something that is done in our office. And if we do it the right way, we can make it very comfortable. There is also a technique to doing this in how we pull the bone marrow. It's not like we just pull it all out at once. We have to hit different areas of the bone to make sure that we get good concentration of MSCs, or mesenchymal signaling cells. So a few different studies here. They compared BMAC to PRP to HA, and they found that bone marrow was better than PRP and HA, and that the PRP was better than the HA, or hyaluronic acid. And then a couple other studies. I don't want to bore you guys too much with the studies, but basically showing that BMAC worked. And a few reasons for that is bone marrow has all the same properties as PRP in terms of the growth factors, but it also has something called IRAP. So IRAP is a potent anti-inflammatory. So there's an older procedure done in Europe many years ago called Regenokine or Orthokine, done in Germany, and this was a way to concentrate IRAP, and I think I remember Kobe Bryant or something like that going over for that procedure. Well, bone marrow aspirate has a potent dose of IRAP and can be helpful as an anti-inflammatory, and I think some companies are trying to just target that. But this also has the cells in it, so mesenchymal signaling cells, which tell your body to come to that area and try to heal that tissue. So it has what's called an apocrine effect to recruit other areas of your body to help. Microfragmented adipose tissue. So again, just one study here. We're not going to go through all the studies, but this is where we pull adipose tissue from you. So a lot of times we can pull it from the abdomen or the back, and it's not like liposuction. We're pulling much less than they would do with liposuction. It's very safe. We do this right in the clinic, and in our clinic we've had great results with it. And this study by Gobi, 120 knees, average age 70, KL 2 through 4. So KL is Kellgren-Lawrence. So this is a scale. So the higher the Kellgren-Lawrence, the worse your arthritis is. So if you have a Kellgren-Lawrence 4, you basically have bone-on-bone knee osteoarthritis. And they did a single injection, and 106 of 120 knees showed improvement in pain and function. So 88% success rate. Outstanding results. We hardly have 88% success rate in anything that we do in medicine. And basically, it reduced their pain and improved their function. So this was a great result. And the benefits to MFAT is MFAT can have more stem cells than bone marrow, especially as we age. And then it also has more of a substrate. So it's thicker, viscous, type of injection than just PRP, and it kind of stays in the joint longer, and it can provide some matrix for the stem cells to kind of sit in there a little bit longer and possibly have a better effect. Okay, this Hernigue study that I alluded to earlier, and he's done several studies, but there's 140 patients, and basically they had bilateral knee arthritis. So they were initially planned to do bilateral knee replacement, but instead he replaced one knee, and then he did a subchondral injection of bone marrow. So he went into the femur, he went into the tibia, and then intra-articular as well. And a lot of these patients had what we call bone marrow lesions. So that subchondral bone that has kind of the bone, kind of like a contusion or edema in the bone, and that subchondral bone can cause a lot of pain. He injected into those bone marrow lesions. And what they found was, number one, most importantly, patients were happier with their non-knee TKA, so the knee that wasn't replaced at 15 years. He found that those bone marrow lesions regressed by approximately 50%. 18% of the 140 patients eventually underwent a TKA, or a total knee arthroplasty, at 10 years after the cell therapy, which means that 80% or 82% didn't need a knee replacement. And the overall incidence of progressing to a knee replacement was only 1.19% per year, which was equivalent to the number or the risk of a revision of the TKA. So the patients that had the knee replacement had the same risk of undergoing a revision as the risk of the patients needing a knee replacement. So pretty awesome results there. Now, obviously, if you want to get those same results, we have to reproduce that, same study, kind of do the same thing. And, injecting into the bone isn't something that we would take lightly, and, it's something that requires skill and appropriate sedation. And, if we want to get the same results, we got to kind of reproduce the study the best we can. But that's kind of looking to the future, and we're probably going to be hearing about this more and more. And each conference I go to, there's, I'm talking to other physicians across the country that are doing similar things, and they're incorporating this into their practice, and we're now having labs on it. So, I think things are only getting better with how we do this. You know, Hernigu also did a study on just intra-articular BMAC versus intraosseous BMAC, and the intraosseous BMAC outperformed just the intra-articular BMAC. So we know it's not just about the cartilage, it's about that subchondral bone as well. So we talk a lot about our 7-star experience, and that is if you are coming into our clinic and seeing me and my team, because it's not just me, but you're not a number. We want to connect on a personal level. We want to learn your goals and dreams. So we have, I have patients coming in every day that are, getting prepped for, a cycling trip in Europe, or they're getting prepped for ski season or mountain bike season, or, they want to, hit a certain peak, or climbing or hunting or whatever it may be. We want to know your dreams and goals, because it's fulfilling to us to get you back to doing what you love. We don't want to just do the procedure and say, see you later. We want to make sure that we're achieving our goal and that you're achieving your goals and dreams. It's all right here. Do I need to click on? Just looked like it was gonna. Okay. We'll walk you through all the options. So just like I did today, we're gonna talk about all the different options and build you a customized plan. So we wanna make sure that we pick the right option for you. And it doesn't have to be orthobiologics. That's just one of the options. So let's come up with a plan that's individualized and customized for you. We don't want to treat just your symptoms. So we want to treat the root cause. And I know this is something that's said all the time now, but like I was describing, we want to treat the knee as an organ, and we want to be your partner in healing. So you don't have to wait and see anymore. If you're still active and not ready for surgery, if you're looking for answers, not Band-Aids, if you're ready to explore a smarter, more holistic approach, book a consultation, come in, see us. We have a great team, and this is not just me. It's a whole comprehensive orthopedic team to help you with any of your orthopedic or musculoskeletal needs. We want to hear your story. We want to get you back to doing what you love, guide you back to your goals. So thank you. Here is my email and contact information, phone number, and then if you want to scan the QR code, that takes you to my website, which has a lot of information on there as well. I also occasionally post on Instagram just talking about different treatments, or just, it's really just purely educational, talking about different conditions and trying to help you get back to, doing the things you enjoy. I think we
have a few questions.
Okay.
Are PRP stem cells or gel shots better?
So I think